Okay, well, welcome everybody. It's 1 o'clock and we're going to get this webinar started. I can see that participants are joining rapidly. We're up to 50, so we'll give it till we get to just over 100 because that's what the number we're expecting. If you're diving in from clinical duties, you want to grab a drink, this is the time to do it. Get yourself sitting comfortably because this is a fantastic webinar with amazing speakers. And incredibly rich content. So we'll just give everybody a minute or so to get themselves settled, and then we will start moving the slides on. So we'll just keep it there for now. We're around about 86 participants at the moment. It's going up rapidly. All right, we're at 95, 96 people.
That's
99, 100. Okay, there we are. We've got the magic 100. So delighted to welcome everybody to this webinar, which is the 8th in a series as part of the National Education Programme Tackling Cholesterol Together. It's all about statin hesitancy, health investment and benefits over time. So we just move on to the next slide, please, Derek. I'll just go over some basic housekeeping. This meeting will be recorded and it will be made available in the Heart UK Tackling Cholesterol Together education pages as soon as ready. There's time to stop and ask questions at the end of the webinar, and a panel discussion will be led by Derek Connolly. Please feel free to ask questions, upvote them in the chat function when it becomes available, and then any questions we're not able to cover in the Q&A will be addressed following the event in a summary of frequently asked clinical questions, and then any questions you provided during registration will also be addressed during the session. Next slide, please. I'll just do a review of the agenda. So first up after me will be Professor Terry McCormack. He will talk to us about statin hesitancy through the eyes of a patient journey. And followed by Terry will be Professor Handrian Soren, who will talk to us about statin intolerance, benefit versus risk, and a balanced evidence-based assessment. And then, as said before, Derek Connolly will lead the questions and answers. I just want to review the learning objectives of this webinar. So we're going to look at hesitancy and perceived statin intolerance from the perspective of a real patient story and their experiences and beliefs. We want to consider the history of the emerging scientific evidence base for LDL-C on patient outcomes, and then that all-important developing that game plan for communicating the long-term benefits of lipid-lowering therapy and combination therapy, and then finally understand what influences LDL-C reduction and what reduction will actually make a difference to outcomes, and then make sense from the literature to balance that benefit risk when we're communicating for patients. So on to the next slide, please. And just a recap here, why is cardiovascular disease a priority? Well, it kills 136,000 people a year. Not just doesn't just result in death, but it's also significant disability. It differentially targets ethnic minority and deprived communities, and moreover, it's preventable. It's also very expensive. It costs 7.4 billion annually, and as a result of this, if we move on to the next slide, we can see that the long-term plan makes cardiovascular disease an absolute priority. And I'll just leave those figures up just for a few seconds. I don't want to read them out to you, but this is why we are here. It's really important that we take cardiovascular disease as a whole entity, that we're not just looking at cholesterol in isolation, even though this programme does focus specifically on lipid lowering. It's about early detection and management of atrial fibrillation, blood pressure, cholesterol and diabetes. And I think we're ready now, after looking at those figures and revising what's bringing everyone here today, is to move on I'm delighted to bring Professor Terry McCormack into this, who will introduce himself and then take us through his own presentation. Thank you. Over to you, Terry.
Thank you for inviting me to join this very interesting panel. So I'm a GP in Whitby in North Yorkshire, and next slide. And I've got a declarations of interest slide here. And the two key things here is that I'm a principal investigator in Vesalius and Clear Outcomes. So Vesalius is the trial that follows FURIA, is a PCSK9 trial, and Clear Outcomes is a bempedoic acid trial, which I'm going to talk for a short time about. SR is a real patient who has given us permission to tell his story. I talked to him just over a week ago, and he's delighted to be able to play his part in this. He's a very delightful chap. So next slide. So this goes back. This shows how old I am. So and how old SR is. So in 1987, SR came to see me with a sad tale that two of his uncles and his father had died in their 50s of MIs, and all within 1 year of each other. And now one of his cousins had died of an MI at the age of 39. And he was very worried about this. So we checked his cholesterol, and the report came back with handwriting on it from the chemical pathologist: mixed hyperlipidemia, type 2B, cholesterol raised 7.2, referred to dietitian. And in 1987, that was pretty much all we could do. And we did refer him to the dietitian, and we were also advised that we should recheck his cholesterol in 5 years' time. Now that 7.2 was probably false. In those days, the cholesterol testing wasn't particularly good, and the standard deviations were quite wide. This is a picture of Framingham. So in 1987, we knew that having a high cholesterol was bad for you, and it was a linear relationship between your LDL cholesterol and your risk of mortality or morbidity. Next slide. But we didn't know that we had any effective treatments. And this is Professor Michael Oliver, who was Professor of Cardiology at Edinburgh, and Derek has fond memories of Michael Oliver. He was an absolutely lovely chap. Now, he carried out a trial in 1963 with clofibrate, and there was no benefit. And so in 1988, a year after I first saw SR, Michael Oliver was telling the world, do not reduce cholesterol. It doesn't reduce mortality. Next slide. Now, in 1991, SR came a year earlier and said, can you check my cholesterol again? And now his fasting total cholesterol is 8.9, showing how inaccurate these measures could be. And again, he's handwritten on the thing. I had to get his paper notes out to see what was going on. Handwritten was Fredrickson type 2B, referred to dietitian, and repeating 3 months this time. Now, when we repeated it, it was the same picture. And so I can't recall why, but I knew that simvastatin was available at that point. And I gave him what I now class as a ridiculously small dose, 10 milligrams, but it was effective. It reduced his cholesterol. Next slide. Now, in 1994, we had the first published evidence that simvastatin did reduce events. And this was a trial designed by the marketing department of MSD, hence the beautiful figures of 4,444 patients in a trial dubbed the 4 S's, the alliteration, Scandinavian Simvastatin Survival Study. It was very nicely designed, but it did work. It proved in this population that simvastatin worked. Next slide. Next slide, yeah. Now, as a result of that, Michael Oliver said in 1996, lower patients' cholesterol now. When the facts change, I change my mind, which is big of him to do that. And in fact, our local endocrinologist had already written to all the GPs in our area when simvastatin came out, advising us not to use it because there was no evidence that it was effective. And he also then wrote when after 4S wrote to all our local GPs saying, I got that wrong. You must start using statins. Next slide. So as coincidentally, in 1994, SR came back to see us. He's now 34. And he, for some time now, has been complaining of pains in his chest, his arms, his legs. The pain in his chest is very disconcerting for someone with the family history he's got. We did his creatinine kinase, which was normal. His meagerly 10 milligrams of simvastatin is still managing to reduce his cholesterol, but he stops taking it and his symptoms cease. And he is adamant he's never going to take a statin again because of that effect on him. But we recheck his cholesterol after he stopped it, and now we've got a total cholesterol of 9.3, LDL of 7.5. Now, I don't think, and Andrew might put me right here, but I don't think the Dutch Lipid Clinical Network score was available in 1994. But if it was, and we'd applied it, his score would be 6. And therefore, he would be a probable familial hypercholesterolemia. And in his best interests, I would refer him to a lipidologist. We didn't have a lipidologist in 1994. We had an endocrinologist who didn't particularly believe in treating cholesterol previously. But I decided that we needed to do something about his cholesterol, so I put him on bezafibrate. And in 2004, when it became available, I added in ezetimibe. Now, no evidence for either of those treatments. Next slide. So fast forward to last week when I talked to SR. He's now 61. He's delighted to be 61 with his family history, and he pointed that out to me. His current main problem is osteoarthritis of his AC joints. That's due to a long career in amateur football. He's had a diagnosis of hypertension and had an adverse reaction to lisinopril with a cough. So that's 2 drugs that he cannot take. And he's got a picture of metabolic syndrome. Next slide. His current medications are amlodipine and candesartan for his blood pressure, still bezafibrate and ezetimibe for his cholesterol, and cocodamol because of his osteoarthritis. And in the panel discussion, we might discuss what we should be doing with SR now. Next slide. Now this is his latest results, and I can't put a pointer on here, but if you look at the dates, you'll see that, and this is typical of most of our patients at the moment, that although he should be having annual blood tests, he hasn't had any since February 2020, the start of the pandemic, and this is a major problem for everyone. So you'll see that his blood pressure was well controlled in February 2020, but we haven't actually measured it since then, which is a worry. We've measured his thyroid back then, and that's a very important test in anyone with cholesterol because it has a major effect on your cholesterol. His HbA1c was then in the pre-diabetic stage. That might be very different when we check his cholesterol and other things in a few weeks' time. His cholesterol was 5.5. And I get very frustrated by the fact that my colleagues put normal by that. There's no such thing as a normal cholesterol. Again, we might discuss that in the panel. And certainly 5.5 total cholesterol is not normal. And yeah, he's overweight. Next slide. Now, Andrew will talk more about this, but we have been making significant inroads into cardiovascular disease in that people are dying of it at a later age. So we basically added 10 years to people's lives. Ultimately, most of us are going to die of cardiovascular disease or cancer, but we're going to die at a later age with both of those conditions. Next. Now, the residual risk is the next key thing, and that's fine. You can pass on to the next slide, because this also shows residual risk. Now, I think Andrew's going to show you a better slide than this, a more up-to-date one. But basically, what we know is that the lower your LDL, the lower your risk of an event. And the question is, can we get that down to 0? can we get rid of residual risk? And I actually firmly believe that we will get rid of residual risk at some point. It won't necessarily be pure, it won't be one factor that will achieve that. But yeah, well, however you lower LDL, it seems to work. If you use a CTP inhibitor, if you use a PCSK9 inhibitor, you lower LDL, you lower risk. Next slide. So, as I said, I'm one of the principal investigators for Clear Outcomes, which is a bempedoic acid versus placebo trial in people who are statin intolerant. So these people are not being treated for their raised cholesterol at all, and they have been brave enough to put themselves forward to take a 50% chance of having no treatment against bempedoic acid. Now, SR was one of my guinea pigs in this, and he was delighted to take part in it. He got as far as visit S2. Now, so he was given a bottle of medication at visit S2. 2 days into that medication, he developed a rash below both knees. 3 days, he developed nausea and vomiting. And on the 4th day, he stopped the medication. On the 5th day, his symptoms resolved. I was very surprised at this and told him so when he came to see me. And he was very surprised when I pointed out to him that he'd been taking a placebo. It was the running phase. Now, we don't tell people that they're taking a placebo. The running phase is important because it clears the trial of people like SR who, clearly wasn't going to be able to progress in the trial one way or the other, whichever arm he fell into. But he was really surprised, and he was embarrassed about it as well. But he needn't be, and as I'll explain in a minute, it's not necessarily his fault. That left us with 25 patients in our centre in the trial. And one of the things that struck me about, because I consented all those patients, one of the things that struck me about them was that they all expressed worry about the fact that they couldn't take any treatment for their cholesterol. The fact that they couldn't tolerate a statin had left them in a worried state. And I sort of had assumed that they wouldn't take a statin because they'd been convinced not to by the press. But it wasn't the case. They genuinely were getting symptoms. Next slide. So the press is a big factor in this, and it's not just in the UK. It's been recognised in countries all over the world that the press tended to be positive on one day, negative the other. So you read in the Express or the Mail or whatever. Monday, it's a great thing to take a statin, and on Tuesday, it's a very dangerous thing to take a statin. And it's confused everyone and it's influenced everyone. Next slide. Oops, slow right down. So just a couple of studies that I'm going to mention that look at this. Now, GAUS-3 is a PCSK9 study. It was one of the Amgen studies with evolocumab. And in this was a statin intolerant group of patients. So they all had to have been intolerant of at least 2 statins. 81% were intolerant of 3 different statins. And they all had to agree to take a placebo or a torvastatin in the running phase, which was a big ask actually of people that have been intolerant of 3 statins. But those that agreed to do that, of those, 25, a quarter reported symptoms with the placebo, and 43% truly couldn't tolerate the atorvastatin. Now, I've seen people argue with this slide that this is proof that people are intolerant of statins, and I've seen people argue the opposite. It's proof that people are not intolerant of statins. It's a half full, half empty story. But in truth, this shows exactly what does happen. In most randomized controlled trials that took place with statins, about 7% of people dropped out because of symptoms. And this is in blinded trials. But in real world data, it's about 16% that report symptoms. So about half of them, something else is happening. It's not true statin intolerance. And the GAUS-3 trial, I don't know if you can see the 3 authors there, but the 3rd author is Rick Dent, and myself and Rick wrote a paper about the safety of ultra low LDL. Next slide, please. So Professor Darrell Francis is Professor of Cardiology at St. Mary's, and he did this very, very nice, very small trial, just 60 patients, recruited via the British Heart Foundation, and they were all statin intolerant, or perceived that they were, and they all agreed to try a statin, again, a placebo, or an alternative treatment. So for 1 month, they all received a bottle, and in one bottle, atorvastatin 20, another, a placebo, and the other bottle was empty. And they were randomized into 3 groups. So some started with the statin, some started with the empty bottle. And then they measured their symptom intensity. And what they basically found was that the statin and the placebo had very similar effects in terms of symptoms caused. But with the empty bottle, you were about half as likely to have any symptoms whatsoever. So this was a general symptom score. And this is seen as evidence of the nocebo effect, that it's actually taking a pill that's the problem here, not necessarily what's in the pill. And they showed that having been that result being revealed to them, half of the patients restarted the statins without side effects. Now, this was a tiny trial, and they called it an N of 1 trial, and they managed to get it published in the New England Journal of Medicine as a letter. It's a beautiful trial because it's so small, so simple, so cheap to do, and told us quite a lot. Next slide. So I know that Hadrian's going to present his game plan for statin hesitancy. Mine is that what the top thing is shared decision making. It's very important that the patient has a say, the major say in what treatment they have. We need more healthcare provider education. We need more patient education. My game plan was pravastatin 20 milligrams plus ezetimibe. See if they can tolerate that, because it's very weak statin, pravastatin. And if that fails, rosuvastatin 5 milligrams twice weekly plus ezetimibe. But often people won't tolerate either of those. My game plan might be very different now. We have bempedoic acid and ezetimibe as a combination treatment available, NICE approved. And for people for primary prevention, that is increasingly where I am going. And for people who've had events, we have inclisiran, which is not a PCSK9 inhibitor, but has a similar effect to a PCSK9 inhibitor. And that also has NICE approval. Now, neither of those treatments have endpoint evidence yet, but Clear Outcome will report fairly soon and may provide us with that evidence. Don't know until we finish the trial. Next slide. Now, this trial is referring to the child-parent study by David Wold, and in Whitby, we took part in this trial. So for 3 years, when the nurses were giving MMR jabs and sticking a needle in one bit of a small child, our research nurse was sticking a pin in their heel and taking a sample of blood, and with a near patient test was measuring their cholesterol. We found 2 babies over the 3 years who had raised cholesterol, and in those 2, we then tested their parents, and in both cases, their fathers, who were in their 20s, had very high cholesterols. So we started them on statins at a very early age. So here's a question. If you can put the poll question up now. And there we go. So I'll ask you to all poll on this. What is the ideal age to start a statin in a patient with familial hypercholesterolemia? Is it 4, 12, 18, 25, 30, or 40? So you can start putting your responses in now. And we'll reveal the result when we've got a few answers. Not sure. I'm not seeing anyone putting any responses in yet.
Hi, Terry. We've got 80% voted, so we've got 128 votes.
All right, great. So let's crack on and see the result.
Okay.
Okay, so the most favored is 18. I'm glad to see that people aren't saying 13, 40. I've done this poll before and people have said it's 40 because that's when NHS health checks take place. The actual answer, it depends on what type of FH you've got. The right answer is if you've got familial, if you've got heterozygote FH, it's 12 is the best age. If you've got homozygote, it's 4. About 1 in 250 people have heterozygote, but we don't diagnose nearly as many people as we should. The homozygote is about 1 in 600,000 people. So it's quite rare, but they're actually easy to diagnose because sadly they're in families who have deaths in their 20s, 30s from cholesterol disease. So next slide, please. This is one of many studies that have shown why that is the case, that we should be starting it early, because atherosclerosis starts early. Now, these are heart transplant donors. A lot of them have died in road traffic accidents, and I might be wrong, but I think they excluded the drivers in case they'd had a heart attack while at the wheel, and it would create bias. But basically what we're seeing is that people, 17% of people in their teens have significant atherosclerosis in their cadaverous samples, and by 40, 60%, more than 60%. And that's why we need to treat early. And the shift in NHS health checks is set to alter from being concentrating on older people and looking more at younger people. Next slide. This is, I think, one of my last slides, and this is Brian Ferentz's work, showing that where your atherosclerotic burden is in terms of symptoms and events. And basically, your burden is there depending on your LDL-C, but worse if your LDL-C is high. Your burden of atherosclerosis begins in your teens, but you don't have your events until you're in your 40s or later. And if we're going to tackle this, we need to be looking at younger people more so than we are at the moment. Next slide. So that's me done with, and I'm going to hand over to Andrian now, who will introduce himself.
So, are we ready to go? Thank you very much for inviting me to this event. And I enjoyed the first talk, an excellent talk by Terry. I just like to just touch base a bit on history and then the value of cholesterol reduction, and then look into harm versus benefit balance. So for those who don't know me, I am a consultant endocrinologist and professor in medicine based in Manchester Royal Infirmary in Manchester. So this is a photo of Nikolai Enchko. He was a doctor in the Russian army, and he conducted probably one of the first randomized controlled trials. Next, please. When he randomized rabbits into a diet based on vegetables and a diet based on lots of egg yolk. And after a period of time, he sacrificed the rabbits, and he discovered that those who were fed on egg yolk, which is high in cholesterol, they developed atherosclerosis, but those who were fed on vegetables, they didn't develop atherosclerosis. And here is his famous say, without cholesterol, there can be no atherosclerosis. This was more than 100 years ago, and it took the medical and scientific community more than 40 years to produce epidemiological data to link CHD incidence to serum cholesterol. And on the left side, it is data from Framingham study, which clearly suggests and shows that incidence of coronary artery disease is basically associated with the level of the serum cholesterol. So the higher the cholesterol is, the higher the incidence of coronary artery disease. Next, please. Then another 40 or 50 years till we saw a real good evidence of a cholesterol lowering trial, which is 4S, the first one, the first statin trial, which was mentioned by Terry. Before that, there were trials on bile acid sequestrants, but this is the early 90s, basically. It was when we saw the first statin versus placebo study. And as you can see here in black, these are the studies comparing a statin to placebo, and in red, studies comparing more intensive compared to less intensive lipid lowering medications. Next, please. And you can see that both is a direct line, almost going through zero. And it's basically lowering cholesterol is beneficial in terms of reducing CHD risk and atherosclerotic cardiovascular disease. And more intensive treatment is better than less intensive treatment. You all know that there are a number of statins. In total, there are 6 of them. The most potent ones are atorvastatin and rosuvastatin, which are most widely used now. And the good news is that both are generics and the cost is minimal, basically. Next, please. So what matters when we embark and start lipid lowering therapy? Basically, the benefit from the lipid lowering therapy, it depends on a couple of factors. So it is important to acknowledge that patients, not all the patients will benefit from, for example, atorvastatin 20 milligrams daily. And even if these patients are all have the same absolute risk, for example, say 20%, not all of them benefit to the same extent. The benefit depends first on the absolute LDL cholesterol reduction. So the higher the absolute LDL cholesterol reduction gives a better and more benefit in terms of reduction of atherosclerotic cardiovascular risk. And next, please. And the absolute LDL cholesterol reduction depends on the pre-treatment LDL cholesterol. So if you have a patient with a pre-treatment LDL cholesterol of 6, compared with a pre-treatment LDL cholesterol of 3, then the patient with the higher LDL cholesterol pre-treatment will attain a better absolute LDL cholesterol reduction when treated with, say, atorvastatin 20 milligrams daily. So this is really important to acknowledge and to focus on people with higher cholesterol, higher LDL cholesterol. And sometimes treatment is justified if the patient has a significantly high LDL cholesterol, even if it's not genetic dyslipidemia, like I mean not monogenic dyslipidemia, the risk is below 7.5 or 10%. The other factor which influences the absolute LDL cholesterol reduction is the method you deploy, how aggressive you are with using medications, cholesterol lowering medications. If you use atorvastatin, 80 is better than 20. If you add ezetimibe to atorvastatin 80, you attain a better absolute LDL cholesterol reduction. And if you use a PCSK9 monoclonal antibody, it is even better, and your absolute LDL cholesterol reduction can be is much better than without it. So that's I like to make this is very clear. The pre-treatment LDL cholesterol is a strong determinant of how the patient will benefit. Of course, absolute risk is important. And the other factor is how aggressive you are with using lipid-lowering medications. Next, please. So when we talk about statin hesitancy or statin intolerance, I like to just show this table to reiterate what I mentioned in the previous slide. If we basically take say 7.5% risk, if the pre-treatment LDL cholesterol is 6, then you need to treat 24 patients to prevent one event, even if the risk is not that low, but you only need to treat 24 patients over 5 years to prevent one event in those people with a risk of 7.5% and a pre-treatment LDL cholesterol of 6. But if the same risk, 7.5%, but the pre-treatment LDL cholesterol is, say, 3, you need to treat 52 patients to prevent one event. And if it is 2, then you need to treat 275 patients for 5 years to prevent one event. So if we have a patient with a risk of 30% over the next 10 years, and it's not unusual to see these patients, they are obese, they have type 2 diabetes and hypertension, and the risk is very high in these patients. And their pre-treatment cholesterol is 4, then for this patient, you only need to treat 6 patients to prevent one cardiovascular event. So if this patient is intolerant to statins or has statin hesitancy, next please, then I would be very concerned, because we are basically not deploying a medication. Can we go back, please? We are not deploying a medication which can reduce the risk significantly. However, if it's a patient with a risk of 7.5% and a pre-treatment LDL cholesterol is 2, then I would be less concerned about statin hesitancy. It's still a concern, but it would be less. That's basically based on the benefit. Next slide, please. So another question which I've been asked and still I'm asked about it is how low is too low? And if LDL cholesterol is below 1 millimole per liter, for example, or even lower, are we concerned? And the answer, before I show you the slide, if there is no side effect, there is absolutely no concern. With LDL, the lower is the better, and there is no limit below which further lowering LDL cease to be beneficial. Next, please. And this is some data from Fourier study. As you can see, in Fourier study, patients continue to benefit from LDL cholesterol lowering with one of the PCSK9 monoclonal antibodies, evolocumab, to very low levels, and this basically down to levels even below 0.5 millimole per liter. And next, please. And perhaps the question we should really ask ourselves is why LDL cholesterol is not too low, rather than why it is low, and should we be concerned and relax our lipid lowering medications. Next, please. So there is statins, there is some controversy when we look at statin intolerance or hesitancy or side effects. If you look at the randomized controlled trials, there has been basically the rate of the statin side effects is very low in these randomized controlled trials. However, in non-randomized controlled trials or observational studies or open label studies, the rate is much higher, as high as 10 to 20%, as mentioned by Terry previously. Some of these can be explained by the media and the patient's perception and thinking, and even sometimes hesitancy from the healthcare professionals. Some of it can be explained also, but not all. This is a minor factor, I think, by the fact that patients are basically, before randomization, they undergo a phase of treatment, which is placebo, as Terry mentioned, a running period. And if some of these patients who have hesitancy or who they may develop side effects to any tablets, they will be filtered during this phase. But this, in my opinion, is a minor factor, but the main factor is the patient's perception, media, and patient's hesitancy. Next, please. So this is a table showing the statin side effects, including muscle, liver side effects. And if you look at the CTT meta-analysis, the hazard ratio of statin side effects compared to placebo is only 1.6. If you look at the data from QRisk, that increases to 4. And if you look at SEARCH, which is basically which is not an RCT, then that increases to 45. And if you look at A to Z, again, it is a non-randomized control trial, then the ratio increases to 10. So clearly there is a discrepancy between randomized control trials and non-randomized control trials or observational studies. Next, please. So what we did with Professor Paul Darrington and other colleagues recently, we looked at basically benefits derived from LDL cholesterol lowering using a statin, and what influences this. And as I mentioned, what influences this is pre-treatment LDL cholesterol, which basically decides the absolute LDL cholesterol reduction. And what we did, we took the data available from the RCTs and also from the observational studies to look into what harm equivalent to a atherosclerotic cardiovascular event may happen to these patients when they are on statins, and how much would this compromise the benefit. In the straight lines, at any risk level, is the benefit. Basically, it is in terms of ASCVD events prevented per 100 patients treated with a statin. If we factor in the harm from events equivalent in intensity to developing ASCVD or a cardiovascular event, then this is represented in the dotted lines. And if you look at the two lines, it's almost superimposed, and the harm, even though this is an overestimate because we took in consideration data from non-randomized controlled clinical trials, then the harm is minimal and the compromise of the effectiveness of treatment is very minimal. And this remains true even for patients with a relatively lower risk of cardiovascular events, which is 5%. Next, please. So I'd like to present one case just to demonstrate that not every statin hesitancy or statin side effects is related to a statin. This is a 71-year-old gentleman, non-type 2 diabetes, coronary artery disease, previous coronary artery bypass graft, hypertension, and hypercholesterolemia. Referred to the clinic, to our clinic, because of generalized weakness and body aches. And the question, is it statin related? And I'm very pleased that the primary care physician referred the patient and asked the question rather than just stopping the medication and say, here we go, you can't tolerate statins, and label them as statin intolerance. So this was a good practice from our colleague. So we saw the patient, we took a history and we examined him, and it became clear that most of the patient is over the left shoulder and he was unable to abduct. And by the time we saw him, it was 2 months off statin treatment, and stopping statin treatment didn't really improve his symptoms. So we arranged an X-ray to look at the left shoulder. Next, please. So if you see from this X-ray, if you have a look, I wonder if you spotted the abnormality. Next, please. But there is clearly a calcific tendinopathy, which is giving this patient the shoulder pain and arm pain. And this was basically, statin was blamed for it. And this is not unusual. Statin treatment are blamed for a list of other conditions. And after further assessment, it became clear that it was not the statin, it was something else. For this patient, we restarted atorvastatin, and we referred him with an advice to increase the dose even further, and referred him to one of the orthopedic surgeons to look into his calcific tendinopathy. Next, please. So no drugs probably in BNF is disadvantaged and blamed for side effects as much as statins. From our experience in our clinics, basically they are blamed for symptoms related to vitamin deficiency, D, B12, and iron deficiency. Sometimes statins were stopped because of stiffness, and further investigations revealed the patient has rheumatoid arthritis. Fall attended A&E, CK, even if CK is normal, basically the patient after the fall feels aches and pains, and statins blamed and discharged the patient, stopped statin and the patient was discharged. Poor mobility, blamed on a statin, and further investigation showed that it's Parkinson's disease, osteoarthritis, TIA, stroke, gout, even motor neuron disease in a couple of patients we saw, and this was blamed, the symptoms was blamed on statins, but later it became clear that statins were not the cause, and many other disorders. Next, please. So when I basically see patients in clinic, usually I look for other causes for the symptoms rather than just blaming it on a statin. And this is because even with the most liberal estimate, more than 80 patients need to be treated with a statin therapy for 10 years for one to experience myalgia, raised hepatic enzymes, or diabetes attributed to statins. So this is, and what we see is much more than this. And as I mentioned, this is we took in consideration data from observational trials. So if anything, this is a significant overestimate. So when we see the patients, we sit with the patients, we educate the patient, we explain the benefits of statins and LDL cholesterol lowering. So I have a couple of slides which shows the lines from the statin trials and how the risk reduces, atherosclerosis regresses. We consider other causes, and we take a detailed history. If necessary, we investigate for other causes. And one other thing we do is we offer stopping the statin for a period of time, usually 3 to 4 weeks at most, and then to ask the patient to see if the symptoms resolved. And if the symptoms hasn't resolved, then we tell the patient this is not statins. Always we re-challenge with the same statin, or if the symptoms resolve after stopping the statin, we try another statin. And if for some patients, a small dose of rosuvastatin, 5 milligrams twice a week, and building up the dose is a good practice. I have to say, many of our patients, after education and discussion and explaining the benefits of statins, and sometimes I even mention some other benefits of statins, for example, its anti-inflammatory effects, a possible positive effect on fatty liver, and etc. So a lot of times the patients are convinced and they don't mind retrying a statin, and some of them, a significant proportion, they tolerate the statin. So I also look at the LDL, and if it's not at target, we always intensify treatment with other lipid-lowering medications like ezetimibe, monoclonal antibodies, bempedoic acid, and inclisiran if appropriate. Next, please. So statins remains the cornerstone of the lipid-lowering therapy, and it has an excellent, probably the best safety profile among all the lipid-lowering medications. All efforts should be made to improve compliance, and some of the reports in the media are unreasonable, and especially with the newer treatment, I hear some reports that take a jab every 2 weeks or take a jab every 6 months and avoid a tablet for 365 days a year. That's totally unreasonable. The safety of statin is the best, even compared with monoclonal antibodies. And when we decide how to intensify treatment, we have to take in consideration the evidence, effectiveness and safety evidence from large phase 3 randomized controlled trials, and the medications who still don't have this evidence. We have to be very vigilant about side effects, especially if it's a novel mechanism of action like inclisiran. I'm pleased to hear from Terry that the CLEAR study is due to report next year, but I think inclisiran study is not due to report the outcome for another 4 or 5 years. Next, please. So in conclusion, there is a considerable and growing burden of CVD, and that's conclusion, I think, is for you, Derek. Yeah, so I think I finished my slides, and I'll hand over to Derek to basically sum up the session.
Thank you very much. It's the two fantastic talks. Just to remind the audience that this is your big opportunity to ask us questions in the Q&A button. If you go to the bottom of the screen, you can ask any questions, and I shall try and moderate the ones as we go along. But, you know, 2021 was a fantastic year in lipids, in that we got 2 additional therapies. We had bempedoic acid approved by NICE, and we had inclisiran. So we now have 5 different ways of lowering LDL cholesterol. But the mainstay, as Handrian has said, is going to be atorvastatin. There were 50 million prescriptions of atorvastatin last year. And then for the 80 milligram dose, the top dose, the 80 milligram dose is £2 a year or less with generic atorvastatin. By the way, ezetimibe is also £2 or less. So for less than £50, you're getting about 70% reduction in LDL cholesterol. And you will see, if you go to the European Heart Journal, we've presented a paper suggesting that the majority of patients that we give those therapies to in combination, because rather like blood pressure, and Terry, you're the president of the British and Irish Hypertension Society. In blood pressure, if you give 5 milligrams of amlodipine and the blood pressure comes from 180 to 170 or less, you're not going to stop there. You're going to add in combination therapies. So exactly the same. If you can't tolerate the statin, we think that you've eloquently shown, guys, that that is not the case in the majority of patients. But if you can't tolerate statin, or the statin doesn't get you anywhere near target, combination therapy seems to be the right thing to do. And today, I'm on the Santorini study as the UK chief investigator. We've shown, give you some privileged information, virtually the same as the Da Vinci study, which suggests that only about 1 in 5 people reach target on statins alone. So we're going to be using more combination therapies, which is what we do in blood pressure, Terry. Is that right?
Yes, accepted in blood pressure. We probably don't do it as much as we should in blood pressure. There is a concept of physician inertia. The average number of blood pressure medications given is 1.8, and it should be nearer to 2.8. About 65% of people need 2 drugs or more to control their blood pressure. But yes, it's more accepted in blood pressure than it is in cholesterol. But I think we're going to have to change our mindset there, because lower is better in both. And yes, to achieve it, we need to be more rigorous. And if you look at the European guidelines, and actually NICE's guidelines, they suggest that we should have lower targets, especially for people with secondary prevention. And I don't think we're quite there. I think that there is a tendency in UK general practice to prescribe a statin and think job is done. But we shouldn't. We should be looking at what we've achieved. And if it's not sufficient control, then we should be adding more therapies, yes. And we've got plenty now. That's the good news.
Absolutely. And Handrian, going back, we've got questions here, and I see Alan Bagnall's asked a beautiful question. The differential between primary and secondary prevention. Clearly what you showed was largely the primary prevention data. As soon as you have secondary prevention, that is a cardiovascular event or clear-cut atheromatous disease on, for instance, a CT scan or a calcium score, and we know that calcium score really does improve the prognostic differential of atherosclerotic cardiovascular disease scores like QRIS 2 or 3. So could you emphasize to us the differential between primary and secondary prevention, Handrian?
Yeah, thanks, Derek. So in secondary prevention, if anything, we really need to be more aggressive with LDL cholesterol lowering. Now, European Atherosclerosis and Cardiology Society, the target for very high risk is 1.4 millimole per liter. And it is important to acknowledge the same rule of the lower is the better. There is no limit below which further lowering LDL cholesterol ceases to be beneficial. It's apply even more for secondary prevention because their absolute risk is higher. And if you have a target like modifiable target like LDL cholesterol, and you are not going to develop side effects with lowering it to very, very low levels, unlike, for example, blood pressure or glucose. So it doesn't make sense if we are not aggressive enough to lower LDL cholesterol.
Yep, fantastic. I'm just going to stay with you, Handrian. Great question we're asked all the time. There is this schism in Britain about non-HDL cholesterol, LDL cholesterol, what we should use. Do you want to address that? You know what I think.
Yeah, so I personally still prefer LDL cholesterol. And this is because all, if not most, randomized controlled trials used LDL cholesterol as a target. And the epidemiology studies, they use LDL cholesterol. And there is a lot of ideas that non-HDL cholesterol basically addresses everything that all the problems associated with LDL cholesterol, like calculation error, estimation error, analysis, but most of these are not correct. And we are used to LDL cholesterol. And now, if we are concerned about triglyceride, then there is a method or a formula, Seth Martin's formula from Johns Hopkins University. It's a very good formula, and it can be used basically to calculate LDL cholesterol, even if triglyceride is higher than 4 or 4.5. And I personally, in my practice, I don't even bother if it's a non-fasting lipid profile. I still ask the lab to calculate or measure LDL cholesterol. Our lab offers direct LDL cholesterol. However, I'm not a big fan of direct LDL cholesterol. I think the future is for apolipoprotein B. Another reason why should we stick to LDL cholesterol is when, in a recent paper from Simon Broom group with my colleagues, when we looked at reclassifying FH based on non-HDL cholesterol, it just created a mess and not interpretable. So it's better to stick to LDL cholesterol.
That's a great answer. And if anybody wants to work out their LDL cholesterol, I use MD Calc, MDCLC. Go into Google and put LDL with that, and you'll find it's easy to calculate. As long as you've hinted it, as long as the triglycerides are less than 3.5, you can easily work out the LDL cholesterol. Going to you, Terry. Terry, you mentioned children and pediatrics, and I know that's one of your specialties. But a couple of questions here about how old you are when you stop a statin. I have a viewpoint there if you've got it in secondary prevention, but what about primary prevention? What age would you say a statin probably is not appropriate?
I think got to differentiate people who've got cardiovascular disease and who haven't. I think if you've got to the age of 75 and you haven't got cardiovascular disease, it's hard to believe that you're going to get much benefit from a statin. You probably will in population studies, but not as an individual. And when I look at health check scores, if I've got a patient who's 75 and has a 15% risk in primary prevention, then they're a very fit 75-year-old, extremely fit. If they're 45 and that they're 15%, that's a very, very unfit 45-year-old. So in the former, in the older patient, I would offer them a statin if they want one, but I wouldn't try and sell it to them. Whereas in the 45-year-old, I really would try and not just sell them a statin, but a whole raft of lifestyle changes because they're in big trouble. So yeah, I don't promote statins in people who haven't got any cardiovascular disease in the over 75s. There's no proof of benefit in that group of people because those trials have not been done.
And in fact, in North America, you can do calcium scores easily for less than $100. And if you have no coronary calcium over the age of 60, the so-called power of zero, you do not benefit from a lot of the therapies. So I suspect when we get into screening, if we ever do, that may be something that we do. Certainly in North America, that's where it's headed. Now, and another question here that we've got, and it's probably the last question given the time that we have left, is when patients stop their statins, what happens? And Handrian, we were talking about this before we came on air. What do you do? What do you think the risk is there?
You mean stop statins, just stop it. Basically, if you stop the statins within a few days, with rosuvastatin maybe a bit more, then the cholesterol and LDL cholesterol will go back to where it was. It's because the half-life of these medications are usually less than a day or two, but rosuvastatin may be a bit more. If you're talking about perioperatively, there is some evidence stopping statins perioperatively, or if the patient is in hospital for other reasons, then if anything, the prognosis is worsened if you stop the statins. That's around surgery, around there is some evidence around the upper respiratory tract infections, even for COVID. And we mentioned this in a recent statement from Heart UK. I hope I answered your question, but I also like to just mention, comment on the elderly. Basically, Terry is absolutely right. There is no evidence for elderly above 75, but that's because these patients are excluded from clinical trials. So if it's a good fit elderly, then there is no reason why should we believe he wouldn't benefit. Still, if he has high cholesterol, I think we should treat him because it's only logical to presume he will benefit. But if it's and there is a paper in PLOS One, I think, from CTT group, they concluded the elderly will benefit, but it's correct, there is no evidence for above 75. But if it's an elderly in a nursing home, very poor life quality and bedridden, or you expect a short life expectancy in some of the patients, and you compare the burden of the tablets to the quality of life, etc., and the benefit, then that's another issue. Then in these cases, of course, it would be logical to avoid burdening the patient with another statin or another tablet if they are not benefiting from it, if they don't live long enough to benefit from it.
Yeah, it's great. So guys, fantastic lectures. I'm just going to summarize in that it's really important to consider lipids at this stage. I did a primary angioplasty on a 40-year-old on Monday night who had no risk factors other than the fact that we measured his cholesterol probably for the first time in his life, and it came back at 7.9. And intriguingly, he had a strong family history of cardiovascular disease, and he'd never had his cholesterol checked. So one of the things that's important, by the time you get to 20, your cholesterol is probably reasonably stable. By the time it's 30, it's stable for the rest of your adult life. Please check everybody's cholesterol, because that's the only way we're going to find these patients with high cholesterol. And, you know, the strongest marker of all is a family history. So if you've got someone with a family history and a high cholesterol, you know what's going to happen going forward. And now we have the tools, all 5 ways of lowering LDL. So it is really important that we discuss it with the patient, and we treat lipids like blood pressure, like brushing your teeth. It is something you have to do every day to stop the events. That's what I passionately believe in, and I'm sure is going to happen going forward. Do you want to have any last words, Terry, first, and then we'll go to Handrian?
So it's very important to floss your teeth as well. So it's not just one treatment.
Yeah, and Handrian.
Yeah, thanks. So just to mention, it's compliance, encouraging compliance with taking statins is very important. And if you have any suspicion, there is a urine test to screen for statins and blood pressure medications in the urine. And I do it on a regular basis. Unfortunately, that means we have to confront the patients if we don't detect it. But this is life. We have to do it, and it is for the benefits of the patient.
Thank you both. I'll hand back to Sue for a final word.
Oh, yeah, thank you. What a panel. Thank you so much to all our 3 speakers. So we've had Dr. Derek Connolly, Professor Handrian Soren, and Professor Terry McCormack. Clear messages coming through there and consistent messages from the 3 panelists. I'd just like to say thank you very much to the 3 of you for your time, your expertise, and we couldn't have had a better panel there of clinical academics with all that knowledge and experience and first-hand research. Leadership as well. So thank you, and thank you to all our attendees. I can see everybody's diving back into their roles now, and just to remind people to register for the next webinar, which will take a focus on diabetes, obesity and lipids with some familiar faces. So thank you once again, and we are now closing the webinar.